Yeah, you know.
Yeah, well, keep asking, because I don't have a laser, so it's this big forward.
This one, this is forward.
Yeah, forward in the back.
Thank you.
And Max is going first.
Yeah.
He knows that.
Yeah.
Wait,
It's back to back. Pause.
yes. Welcome back, everybody, to the last session of the day. I think we'll get started. We have a very intriguing session. I'm Nick Zaromsky. I am privileged to co-moderate with my friend and a longtime Pancreas Club supporter, Dr. Ulrich Adam from Berlin, Germany. I have a public service announcement here for those who are interested in pancreatic cancer margins. My colleague, Dr. Alexandra Rook from Indiana University, is putting together a multi-center group. Alex, I don't think is in the room right now. Alex is in the room. Stand up, please. And if you are interested in this, the goal is to define the optimal definition of R1 resection and the impact of margin status, especially neck margins on outcomes. Could we have the next slide, Jared? Thanks. And she has already highlighted a number of centers around the world, Asia, Western Europe, and the US and South America. And so please contact her if you're interested in supporting this study. Good point, Bill. We'll do that. Maybe we'll put the slide over the bar at after the meeting too. Yeah. So we'll try to bring these slides back up here in the middle of the session too. Thanks. Okay. Without further ado,
Well, we have to start the session with actually second scheduled presentation elucidating the optimal use of mitigation strategy for improving pancreatic fistula fistula rates after pancreatic duodenectomy. It is given by Max Judisch from University of Pennsylvania.
Thank you, Dr. Zazon and Zaromsky, and to the Pancreas Club for the opportunity to present our work on optimizing fistula mitigation for the Whipple. We have no disclosures. Postoperative pancreatic fistula is a dominant problem in Whipple resections, occurring around 15% of the time, with many attendant effects. Putative causes of fistula include compromised wound healing, biochemical erosion, physical disruption, and surgeon-controlled factors, which will be the subject of this talk. A brief aside on the history of studying fistula. 2005 was an important year. An international consensus was arrived by a study group, the ISGPF, and this standardization was direly needed. A 2004 paper by Claudio Bassi found that there were 26 distinct definitions of fistula at play in the literature. After this standardization, though, research into risk factors and mitigation techniques was markedly enabled. Umpteen studies have looked into the various risk factors that play into a fistula, and they've yielded findings such as patient demographics, innate characteristics of the gland, and circumstances in the operating room. But realistically, as clinicians, we can only affect this last category. Surgeons have a variety of techniques to try to influence a positive Whipple outcome. Most of these occur before the closure of the abdomen, and some of them occur postoperatively. To our count, this is around 12 distinct techniques that a surgeon has at his or her fingertips. Looking at the past 30 years of research into fistula mitigation, the highest level evidence in our flagship surgical journals consistently show equivocal value. This goes for drains, we might not need them. Stents, which show myriad contradictory findings. Somatostatin analogs are highly controversial. PG and PJ appear to have similar fistula rates, but bleeding after PG might be more common. And no study has shown benefits for sealants. Notably, these studies look at these fistula mitigation techniques in isolation. But the Whipple is an enormously complex operation, and so there's likely interplay between these factors. It's more complicated than just pulling a single lever to try to influence fistula rates. With this in mind, we propose that a good guiding principle could be to minimize the number of interventions, given that each intervention has potential downsides and several are quite expensive. With all this buildup, our objective was to investigate the interplay between various fistula mitigation strategies and to discover an optimal risk-informed approach. Here's how we went about it. We utilized the large retrospective database compiled by the Pancreas Fistula Study Group. Variables collected included patient demographics, the fistula risk score elements, and intraoperative mitigation techniques, and the primary outcome of clinically relevant fistula. Because this was a study on the effect of surgical decision-making, we only included those patients with complete information on intraoperative mitigation. And so that took the cohort down from 9,000 patients to 7,000 patients. A brief word on the fistula risk score. It's fundamentally a simple 0 to 10 scale that is driven by 4 dominant risk factors. In this study, we stratified patients into the 4 risk zones, going from negligible to high risk. Here's what we found. This is some basic information about the overall cohort. The median FRS was 4, and 15% of patients developed a fistula. Regarding the mitigation that was used, drain use was ubiquitous. Stents were applied in around 2/5 of patients, octreotide in around 1/5, and other mitigation techniques were rarely employed. Among patients who had a drain placed, those were pulled early less than half of the time. Looking at the value of each mitigation technique in isolation, so the outcomes of patients who received the technique versus in which it was omitted, PG appeared worse overall, but this was driven by the high-risk zone, whereas the results were similar in the other 3 zones. Stents were associated with higher risk after placement, but risk stratification reveals that this is driven entirely due to selection for higher risk patients. Sealants did not prove valuable. And octreotide, like in other studies, other previous studies using this cohort, was associated with greater rates of fistula, around twice as often. Patients who received octreotide leaked about twice as often as patients who did not receive octreotide across the risk zones. Drains were only significantly beneficial in the moderate risk zone, but notably in the negligible and low risk zones, they were non-significantly associated with higher rates of fistula. Early drain removal was the only consistently positive intervention in this cohort. Now we're going to look at the mitigation techniques in combination. So we can build in complexity from full omission of mitigation all the way up to, in this cohort, that's 5 different mitigation, 5 different techniques combined. Of the 48 possible bundles among combining the 6 different mitigation strategies, we observed 32. And that's a testament to the robustness of this cohort that we were able to observe so many different combinations. Taking you through the optimal bundles in each risk zone. In the negligible zone, which is characterized by very low risk patients, patients who have a firm gland, who have PDAC or pancreatitis pathology, who have a grossly enlarged duct, and have minimal blood loss. Among the 19 distinct treatment approaches that we observed, the patients were best served by full omission of mitigation. However, because the leak rate in the negligible zone is so low, this was not statistically, this did not perform statistically significantly better than the other bundles. The low zone, like the negligible zone, was best served by full omission of mitigation. However, unlike the negligible zone, this was statistically significantly better than the rest of the bundles combined. Turning now to the moderate zone, we saw 31 distinct bundles used by surgeons. And the best performing one was to place a drain and to pull it early. This significantly outperformed the rest of the bundles. And in the high risk zone, the best bundle was to place a drain and a stent and to pull the drain early. This was again significant. So presentations are short, and so we couldn't walk you through the entire thing, but just to impart that we did do our due diligence. We looked at every bundle in the negligible zone, in the low zone, in the moderate zone, in the high zone. We also looked at the marginal benefit of adding one technique at a time, and also to test whether this was driven by surgeon selection. We looked at the subset of patients for surgeons who both did the optimal bundle and the non-optimal bundle. We compared their outcomes. So putting it all together, this table shows the risk zones with their frequency of occurrence in the series on the left, In the middle, we see the value proposition for each of the 6 prime mitigation techniques. The gray equal sign indicates a equivocal value proposition, whereas green is positive and red is negative. Whereas on the right, we show the optimal bundle for each zone. So that's full omission in the negligible and low zones, which accounts for about 1/3 of your patients. Whereas for the other 2/3 of patients, placing a drain and pulling it early is valuable, and the potential addition of a stent is useful in the high-risk zone. Some keen-eyed observers might see that there appears to be a contradiction in this high-risk zone, where stents seem neutral value, but actually appear in the optimal bundle. So this is not. This conundrum can be resolved by thinking back to that gear schematic from the beginning. Because all these techniques are interacting with each other, what could also be influencing fistula rates in the high-risk zone? So when we look at patients who received at least a drain and a stent, a full 1/3 or more than 1/3 of those fistulas occurred simultaneously to the use of either octreotide or PG, which were previously shown to be negative value mitigation techniques. And so sort of these higher fistula rates among those patients who received a drain and a stent are sort of diluted by the inclusion of negative value strategies. So throughout this entire cohort, the optimal bundle was used just 14% of the time. And if we project optimal mitigation usage to the rest of the patients who did not receive optimal mitigation, we could see up to 6-fold improvement. And the statistics suggest that even a conservative estimate of this improvement would see the fistula rates in the cohort cut in half, which is pretty good. So there are a few concepts that emerge from this work. So first of all, this is sort of introduces the idea of personalized medicine or personalized care for our pancreatic surgical patients. You can also think of these sort of, we've intentionally used the word bundle to evoke a sort of ERAS style package where you might consider this as something that could contribute to better recovery after surgery by avoiding a fistula. Additionally, early drain removal, which was the most consistently positive intervention in this study, is backed up by excellent randomized data, both from a 2010 Claudio Bassi paper and by a 2015 paper from McMillan and colleagues. Our findings are also substantiated by a survey published in Surgery that looked at the behaviors of 4 master pancreatic surgeons who reported career fistula rates of less than 5%. Their choices in the operating room were characterized by the use of a PJ, anastomotic location. They relied on drains. They were selective in their stent placement. None of them used octreotide. There was very little reliance on sealants, and 2 of those 4 master surgeons employed early drain removal. So in conclusion, in this largest, most granular look at Whipple techniques to date, the best value appears to be from simplified, risk-informed application. Many techniques that were trusted in the past, such as PG or octreotide and sealants, did not prove their value. And the optimal approaches identified herein were widely underutilized. I do want to note that not all mitigation techniques were studied, such as autologous patches to mitigate the effect of pancreatic juices on, say, the GDA stump. And so we're not going to suggest that you avoid something if it wasn't studied in this paper. But I think a good maxim to use is the one from Dr. Paul Gregg out of the Toronto training program of if it's cheap, it's safe, and it might work, why not? We are indebted to the institutions that comprise the Pancreas Fistula Study Group. And the take home from this talk is that the balance between sophistication and simplicity is risk-informed minimalism. In other words, follow the KISS principle. Keep it simple, surgeon. I welcome any questions at this time.
Very nice work and very well presented with the conclusions for our daily work. Papers open for
Henry
discussion.
Pitt, Rutgers, very nice. I mean, this work is very important and still really needs to be done. When we look at the NSQIP pancreatic, clinically relevant pancreatic fistula data over a decade, we have not made any progress. You know, we were running 12, 13%. Now we're running 13, 14%. If anything, it's gone up slightly. The one, I think, game changer recently is the Pip/Tazo versus cefoxitin antibiotic trial, where not only were the infections better, but the pancreatic fistulas were statistically significantly less. Interestingly, you know, prior to the trial in NSQIP, only about 35% of people were using a broad spectrum penicillin. Ryan Ellis at Indiana has recently looked at some not presented data yet that show that 70% of people have switched to Pip/Tazo. So have you looked at broad spectrum penicillin as a risk mitigation possibility in your data?
So we have not looked at it. I am aware of it, like, for example, the D'Angelica trial that was published in JAMA. So to my knowledge, that's a very recent notion that's been proposed. The D'Angelica paper was in 2023, I believe. And so the vast majority of this study cohort far predates that time. And so we just didn't have the data on that in this cohort. And about your comment on the not making progress, you're going to love a slide in this next presentation.
Hello, Giovanni Marchegiani, Padova, Italy. First of all, congratulations. This is just great, but I had no doubt whatsoever. I just have a comment on these techniques for the high-risk group. So to me, it makes complete sense, you know, to just mitigate according to the risk, and the FRS really changed our practice. And so stents were basically a factor in the high-risk group. Can you expand a little bit more the added value of stent plus early drain removal? Because whilst the early drain removal is a key factor from the intermediate risk zone and also the high risk one, the connection, the interplay between these two bundles might be more controversial, because of course when you put a stent in the anastomosis, particularly an external one, you're basically interfering with the mechanical of the anastomosis itself. So I found it a little bit more difficult to understand how the early drain removal policy would apply if you have a stent in, but apparently from your analysis they turn out to be like a good combination, even though even the value of the amylase in the drain when you have stents in might be a little bit different because you actually have a stent inside. Can you expand a little bit more on this concept?
Yes. So my understanding of the value of an externalized drain is that it shunts the amylase away from the anastomosis and enables healing in that case. And drains, to my understanding, don't really prevent a fistula, but if one happens, then it takes fluid away from that location. And so we might downgrade like what might have been a grade C fistula to a grade B fistula. A downside of having a drain in place, though, is so there's a foreign object, but also depending on the type of drain, especially if there's a closed suction drain, that could actually be interfering with the healing process by interfering with the deposition that fibroblasts and other cells are doing. And so I don't have solid basic science to back this up, but something that could be a reason why early drain removal is so proves so effective in our series is that the drain's in place to get the patients through that initial hump of are they going to leak in the first 3 days, and then pulling it early avoids the potential negative effects of having a drain in for really long.
Yeah, you convinced me. Yeah, I agree.
Thank you.
Short question. Does it have to be an externalized stent? And how do you manage that? Is it open to drainage until day 7 and then you close off the external stent? And when do you pull it out? And how do you prevent it from being pulled out too soon? And
Yes, so the vast majority of stents in the high risk zone were externalized. And when we looked specifically at that drain plus stent plus early removal bundle in the high risk zone that performed so well, most of that benefit was shown from patients with externalized stents. I do not know in the series how externalized stents were managed. I think that you would probably get a better answer on that regard from my mentor, Dr. Vollmer.
Back to the question beyond the last year you had some of the SSAT that showed when you have externalized stents, you actually have a steeper degree of decline in family very fast in the first few days. So that is the kinetics aspect of that work.
This is a great discussion. I'll point out that Max is a pre-medical student and is doing an excellent job, not just with the presentation, but handling some of these sophisticated questions. And he's doing such a good job that we're going to keep him up here for the next paper, which is entitled Elucidating the Optimal Use of Mitigation Strategies. I'm sorry, we just heard that one. Improving fistula rates for pancreatoduodenectomy by targeting the most clinically impactful risk scenarios with optimal mitigation. Dr. Pitt is waiting anxiously for the great slide. Max, go
Yes.
ahead.
Yeah, so you can't get rid of me just yet. Taking this topic in a little bit of a different direction. Again, no disclosures. So as Dr. Pitt brought up, we haven't had much progress in a while. So Alan Oldfather Whipple, his first patient died 30 hours after the operation of an anastomotic dehiscence. We no longer use catgut for those reconstructions. In that time since, rates have kind of flatlined around that 15% level. This stagnation this flatlining isn't fully stagnation because modern series are more enriched with higher risk pathologies like cholangiocarcinoma versus those mid-century series were really primarily pancreatic cancer. As a quick recap of this last talk, we showed that tailoring mitigation to a patient's risk level was a positive choice to make. But to borrow an analogy from the garment industry, if we're tailoring our mitigation to the patient, can we take basically our customers from an off-the-rack experience to a bespoke experience? And so we can start out with the fistula risk score, this 0 to 10 scale. In the previous talk, we used the fistula zones extensively. But we can combine these 4 different risk elements into 80 unique scenarios that were defined previously in the fistula risk score catalog. So these 80 scenarios, they have variable occurrence. So that blue is just the N in a previous series. But notably, the risk associated with each of these scenarios is completely divorced from their frequency of occurrence. And so going back to this idea that fistula rates have been flatlining, we ask how far down can we get them to go? And perhaps more importantly, how can we actually go about achieving that change? So to use an analogy that has personal relevance, here are a few pictures from a blueberry farm that my family used to run in Western Michigan. So each year, there are multiple threats to your crop. Some of them are common, or some of them are ubiquitous, but don't actually supply much damage, like unseasonable weather, which just might make the harvesting your crop a bit more difficult. Some are common and can actually cause a fair amount of damage. So that picture on the right is the mummyberry fungus, which can ravage really good berries and destroy a lot of value. And some of them are rare but ruinous, such as a prolonged drought. That's just going to wipe out the farm's productivity. So each year, you as a farmer only have so much money that you can spend alleviating these potential threats. So in other words, what's your mitigation strategy? And so extending this analogy back to the fistula risk score catalog, we can think of those low zone cases as the unseasonable weather. They're pretty common, but you're not really worried about them very much. And those high risk cases, which we dread seeing in the operating room, is like the prolonged drought. They don't happen very often, but when they do, it can be pretty bad. And so these sort of more moderate risk cases are like that mummyberry fungus. They're pretty common, and in aggregate, they can cause a lot of damage. And so with that in mind, if I told you that the best course of action when running a blueberry farm was to spray antifungals, we might ask how we can improve the seemingly static fistula rates by attacking these snares that produce the bulk of the fistulas, just like how the mummyberry fungus caused most of the damage. And we're looking to do this through application of the most effective and tailored mitigation approaches. So this is how we went about this one. So we used basically the same construct as last time. But we also needed to figure out where most of the leaks were coming from. So this slide, I overlaid the percentage of leaks coming from each of those zones. So the negligible and low zone contributes only 8% of leaks. In the high zone, while each scenario leaks fairly often, produces less than a third of all total scenarios. So almost 2/3 of fistulas are coming from those moderate risk patients. So thinking more concretely about which fistula scenarios we want to look at, we could examine we could target the most frequent scenarios that you'll see most often on the operating room table. We could look at those most severe scenarios that leak the most often. Or we could look at an amalgamation of those two concepts, a hybrid that we call the most impactful scenarios that produce the greatest raw contribution of fistulas. So the 10 most impactful scenarios are these 10 right here. And so again, the blue is the rate of occurrence, and those red X's are showing what the fistula rates were there. And together, although these represent only 1/3 of your cases, these contribute over half of all fistulas in our series. So here's what we found. So these are the 10 most impactful scenarios ranked by raw fistula contribution. So scenario 60 is at the top because that was the scenario that contributed the most fistulas, and then 43 is at the bottom there because that produced the 10th most fistulas. So notably, these three scenarios, so 60, 47, and 20, are respectively the second, third, and fourth most common scenarios that you'll encounter. The most common one being scenario 1, or the FRS 0 patient. So these top 10 scenarios produced over half of the fistulas, and they did that by having a significantly higher fistula rate, over double the rest of these scenarios combined. So these are the characteristics that play into defining these scenarios. All 10 of them are characterized by a soft gland. 7 of the 10 have pathology other than pancreatic cancer or pancreatitis. Only 2 of them have enlarged ducts, and all 10 of them or rather, none of the 10 are characterized by grossly elevated blood loss. Taking you through the mitigation that was used in each of these scenarios, drain use was ubiquitous. Stent use increased with scenario number and thus with scenario risk, while early drain removal decreased with scenario risk. Octreotide use was pretty consistent throughout, and the other mitigation techniques were all pretty rare coming out at the bottom. So that's duct occlusion, sealant use, and PG. Here's the optimal mitigation that we found for each of these zones in a similar way to last talk. I want to highlight these 4 scenarios though. These 4 stood out to us because they had different optimal bundles compared to what we would expect based on what fistula risk zone they fell into. And so 31, 47, 60 are though in the moderate zone, so we would expect drain plus early drain removal, actually benefited from the placement of a stent. Whereas scenario 70, which is the high risk zone, did not show value from the addition of a stent. So once again, the optimal bundle was used very sparingly. And in this case, we projected that if practice changes in just these 10 scenarios, we can move the needle down from 15% fistula down to a hypothetical 8.7% fistula. And that's just by addressing these 10 scenarios. No change in any of the other patients. And there's more. So during our analysis, scenario 10 stood out to us. It's just a low risk, and it's uncharacteristic of the low risk zone. It has a soft gland. All the rest of its characteristics are not higher risk, but it does have a soft gland. It is the 12th most frequent scenario that you'll encounter. And it has a pretty high fistula rate at 10%. So in this case, we found that it was best served by placing a drain and then pulling it early. And this demonstrates that, so in the last talk, we showed that in the low zone, full omission of mitigation it will serve your patients best. But this is an example of a low risk patient who's actually well served by placing a drain. And this was statistically significant compared to the rest of the bundles. So in conclusion, this expansive experience shows a path toward driving down those stubborn fistula rates below that 15% plateau. And acknowledging that there's a lot of detail in here, we aren't expecting you to memorize like what all these different scenarios are. So this is when we plug the FRS app. You can scan the QR code, and that should take you to the iOS App Store, or you can go to fistulariskScore.com. It provides you a way to log your cases and also to plug in the different values that you have during the operation. You're scrubbed in, so it won't be you, it'll be the circulating nurse. But then you can check out what your risk is based on your zone, based on your FRS number, or even your scenario. And you can also look up what we would suggest you use for mitigation. Again, we would like to thank the institutions that contributed to the Pancreas Fistula Study Group. And this is your takeaway from this talk. So Fistula Risk Score app, and these are the 11 scenarios that we looked at in this talk. Thank you. And any questions?
Thank you. A great presentation. I was wondering if you could comment on the use of PG in this data set, because a number of studies showed that, including our own data, showed that it's relatively useful technique in these high risk scenarios. In your case, in your data set, I noticed that PGs were done in like 3% of the cases.
Yes.
Do you have any idea how many were done per surgeon, per center? Because if it's done in such a low percentage, It might have been done as a desperation procedure in cases where nothing else would work. So if you have such a low experience with that, it could explain this negative result.
Those are good thoughts. I don't have an answer for you off the top of my head regarding numbers.
I I have a question from a methodologic perspective, and it's going to be to you, Chuck, directly. Early drain removal presumably is because the amylase is low and there's no fistula there anyway. So how did you calculate that machination when you put this into your statistical construct? So isn't early drain removal a surrogate for not even having a fistula in the first place?
Oh, exactly. Early drain removal, not all in vogue at the beginning of the series, and it was towards the end. So I can't tell purposely done. We do not have amylase levels.
And one other quick question, the stent, did you combine internal stents and external stents as just all stents? And how do you feel about differences between internal and external stents? Yeah.
Very clearly, that's currently a high risk case of all external stents. I'm getting our value from that. We have on the same data set produced paper that shows lack of value in internal stents in preventing fistulas and particularly in high risk area.
Yeah, great. Excellent work, guys. Thanks for kicking off the session.
Thank you.
Next paper is impact of fistula risk score on the severity of postoperative pancreatic fistula following pancreatiduodenectomy, and it's presented by Kenjiro Okada from Mayo Clinic, Rochester.
Thank you for presenting a great opportunity to present our work. We have no COI. Postoperative pancreatic fistula is a major complication following pancreatiduodenectomy. Fistula risk is assessed by conventional fistula risk score or newly proposed simple classification. However, whether these can predict fistula severity is still unclear. The aim of the study was to evaluate the relationships between FRS, simple classification, and fistula severity. We also aim to identify the optimal predictive thresholds. We retrospectively reviewed 2,034 patients who underwent PD at the Mayo Clinic between 2007 and 2023. In this cohort, grade B fistula was divided into grade B1, which is conservative treatment, and B2, interventional treatment. First, we analyzed FRS and fistula severity. Second, simple classification and fistula severity. Finally, we evaluate the optimal threshold by using the ROC curve. In this cohort, clinically relevant POPF rate was 15.6%. Grade B1 was 4.4%. Grade B2 was 8.9%. Grade C was 2.4%. This figure shows the association between FRS 4 categories and fistula severity. As the FRS increased from negligible to high risk, grade B1, B2, and C rates also increased. Based on these ROC curves, to predict grade B1 or higher, optimal FRS threshold was 5 points. Grade B2 or higher was 6 points. Grade C was 7 points. Next, this figure shows the relationships between simple classification 4 categories and fistula severity. As the simple classification increased from A to D, grade B1, B2, and C rates also increased. Here, we assume that simple classification from A to D represents a continuous scale from 1 to 4. To grade B1 or higher, optimal simple classification threshold was class C. Grade B2 or higher was also class C. Grade C was class D. In conclusion, both FRS and simple classification were closely associated with fistula severity. FRS 567 and simple classification CCD may help stratify fistula severity and support post-operative management. Thank you for your attention.
Very nice work and well presented. I think it underlines the importance of applying the risk score in daily practice. Any questions from the audience? So then we move forward.
I think in
Thank you.
I'll ask
Okay.
one question and really excellent job presenting this work. This is on the heels of fistula mitigation strategies. How are you guys using this in Rochester, using these data to mitigate against problems with pancreatic fistula?
For the treatment strategy for the grade B pancreatic fistula. So this result shows that predict the FRS 567 and the simple classification CCD predicts simple fistula severity. So for example, FRS 7 and the simple classification D, these are high risk patients. So this it is an important issue to predict progression to grade C fistula. So for high risk patients, we proactively perform their, for example, interventional treatment, drainage, careful drainage, or for high risk patients, the prolonged fasting after surgery, or the use of octreotide and so on.
Great. Thank you very much.
Thank you.
Our next paper is number 35 in the program and is eligible for the best paper. The title of the presentation is Post-Pancreatectomy Liver Injury, PPLI, a new entity in the modern era of pancreatic cancer surgery, from Alicio Marchetti from the NYU group.
So thank you again for the introduction and for the opportunity to present our work. So I have nothing to disclose, and I would like to start with a brief discussion on liver surgery, and specifically on liver transplantation and colorectal liver metastasis. In liver transplantation, we work on healthy liver, where we perform vascular anastomosis, including portal vein and hepatic artery reconstruction. In contrast, in colorectal liver metastasis, the increasing use of neoadjuvant chemotherapy has raised concern about the hepatotoxic effect of multi-agent chemotherapy. And both these factors contribute to the most relevant complication in liver surgery, that is liver failure. However, this is the pancreas club and not the liver club, so let's back to talk on pancreas. And specifically, I would like to talk about locally advanced pancreatic cancer, where I think we can find some similarity with the previous features that I described. Indeed, most of patients with locally advanced pancreatic cancer receive prolonged preoperative chemotherapy, often including hepatotoxic agents, and some of them receive complex vascular reconstruction involving both portal vein and hepatic arteries. So we ask ourselves if liver injury could be a relevant complication also in pancreas surgery. And yes, recent evidence report an incidence of ischemic liver complication up to 42% after hepatic vessels reconstruction, and up to 80% of death were related to liver failure after pancreatectomy with hepatic artery reconstruction. However, a standardized definition of liver injury in pancreatic surgery is lacking, Indeed, there are several terms as liver perfusion failure, liver ischemic complication. For this reason, we designed this study with three main goals. So the first was to propose a standardized clinically based definition of liver injury in pancreatic vascular surgery. The second one was to evaluate the incidence of clinically relevant post-pancreatectomy liver injury after pancreatectomy involving hepatic vessels resection. And then we would like to find some perioperative predictive factor of this complication. And to do that, we designed this study that is a single center retrospective study, including all consecutive patients undergoing pancreatic resection with hepatic vessels resection between 2013 and 2024. And we defined the clinically relevant post-pancreatectomy liver injury as a development of acute liver failure after surgery and or the indication for invasive treatment for liver complications such as percutaneous drainage, angiographic intervention, and reoperation. Since 2020, our practice include routine blood tests every 6 hours until postoperative day 2, and then every 24 hours until postoperative day 5. And then we also perform immediately after surgery Doppler ultrasound evaluation to assess the patency of all vascular reconstruction, but also to evaluate resistive index and peak of systolic velocity in all hepatic arteries reconstructed. Then we perform a logistic regression analysis to identify factors associated with the development of this complication. We include 116 patients, and 13% of them develop clinically relevant post-pancreatectomy liver injury. And comparing the preoperative characteristic, we didn't find any significant differences between these two groups. However, we found trend toward a higher rate of FOLFIRINOX in patients who develop liver injury. However, this difference was not statistically significant. Intraoperatively, patients who develop liver injury more frequently underwent to more complex vascular resection involving both portal vein and celiac axis or hepatic arteries resection, and also more frequently receive interposition graft for the hepatic artery reconstruction. Regarding postoperative outcomes, we didn't find any difference for length of hospital stay. However, patients who develop liver injury had significantly higher rate of hepatic thrombotic complication, hemorrhage, reoperation, and 90 days readmission. And we also found a strong association with postoperative mortality, with 47% of mortality rate compared to 3%. So then we analyzed the early postoperative biochemical data, and in liver injury group, we found a significantly higher level of bilirubin, AST, ALT, ALP, INR, and lactate within the first 48 hours after surgery. And also we identified 42 hours after surgery as a critical time point in this group. We then analyzed the data on Doppler ultrasound evaluation, and patients who developed liver injury had significantly lower resistive index measure on proper hepatic artery during a second ultrasound evaluation performed within the first 48 hours. And consistent with the data from liver transplant surgery, we also observe a trend toward a 0.1 lower resistive index measure on hepatic arteries during the Doppler evaluation performed immediately after surgery. So finally, we perform a logistic regression to identify the association with the development of liver injury, and among type of pancreatectomy performed, type of vascular reconstruction, biochemical data, and Doppler ultrasound data, only the peak of ALT within the first 48 hours was significantly associated with liver injury. So in conclusion, we confirm that liver injury is a critical complication also after pancreatectomy with hepatic vessels resection, particularly when both portal vein and hepatic artery are resected, with a significant related mortality around 50% in this group. The patient who developed liver injury had significantly higher levels of bilirubin, AST, ALT, ALP, INR, and lactate. So biochemical tests during the first postoperative days are critical in this patient, as well as Doppler ultrasound evaluation with lower resistive index in liver injury group. The only predictive factor for the development of this complication was the peak of ALT. And so further study will be necessary to validate this clinically based definition, identify more perioperative predictive factor, and also identify mitigation strategy and effective treatment. Thank you for the attention.
Excellent work. Dr. Evans.
Yeah, very nicely presented. Are you just confusing liver injury with either your artery or your vein goes down? So I assume that the majority of the patients who had problems here, you reconstructed in some way the hepatic artery or the portal vein or both, and then one or both of them occluded.
Not in all cases, most of them, yes. So we have 38 patients with hepatic artery reconstruction, and in this group, the rate of liver injury was around 45%. So yes, I think this complication is present mostly in patients who had problems, postoperative issue with portal vein and hepatic artery reconstruction, but I think it's important, the early biochemical evaluation and also a Doppler ultrasound evaluation to early identify this patient, because I think in locally advanced pancreatic.
Yeah, you have a couple things that are a challenge here. Right, I mean, none of these livers are normal after systemic therapy.
Yeah.
And then on top of that, you're putting a biliary enteric anastomosis, so that basically you have to have an artery and a vein going to each side.
Yeah.
And I think you can then kind of predict who is like ultra high risk. So I would say the ultra high risk patient needs both, has type 1 hepatic arterial anatomy, and needs hepatic artery resected and the portal vein in order to remove the tumor. And I think in that patient, you want to make sure that that's a healthy patient who has really responded beautifully to induction therapy. In contrast, you have a patient who has a replaced right hepatic, and what's encased is the native, if you will, common hepatic, or they have a large replaced left hepatic that's out of harm's way. Those patients are a little bit lower risk. You just have to know, you be careful. But I think it's wonderful that you brought attention to this, no doubt.
So Doug, before you sit down, can I ask your question, Chris, before you get to this? I think the point about bacteremia is huge. And
huge.
I mean, not just the liver injury from, for sure, the liver injury from the systemic chemo, but the bacteremia is a huge deal. So what is your strategy for perioperative antibiotic management in those patients? Do you culture the bile? How long do you keep them on antibiotics? Somebody, you're going to take the vein or the vein and the artery.
There's probably not a medical student in the United States who knows less about antibiotics than me. So I'll just say that to begin with. But we definitely culture the bile on everyone. And I remember a discussion at this meeting many years ago when people were debating over 3 to 5 days of antibiotics in biliary stent patients. So that's what, we tend to do. If the white count's normal on post-op day 3, then we typically stop the antibiotics after 72 hours. If the white count isn't normal, or by then we have the cultures back and there's something strange that grew out of it, I probably abuse antibiotics a little bit. I don't know, has Dr. Pitt gone to the bar already? I hope. Yeah, so I would just admit to that. But I'm kind of liberal in these patients. And, you know, some of these patients who have had a biliary stent, and people react to biliary stents differently, right? And some of them, I mean, it's actually malodorous when you open the bile duct. And I think that catches our attention, especially if, you know, if you're replacing the artery or the vein, for example.
To just further actually address Dr. Evans's question, and I don't know the answer, so I'm going to ask you, what is the thrombosis rate? Because what we're trying to find is really ischemic time in the operating room and what we do in the operating room, assuming then we have patent vessels, you know, then the pitch is already thrown. So warm ischemic time, and we sequence the way we do artery first and then vein. But what is the actual occlusion rate, like catastrophic occlusion rate?
I mean, you bring up an important point
Yeah.
too. I think with these chemo-treated livers, you don't, it's not like a liver transplant where you can occlude, or at least this is
Yeah.
my thought, where you can have occlude the artery and the vein at the same time. I personally would never do that.
Yeah.
You know,
And we
just one at a
don't, we
time.
do it sequentially.
Yeah.
Yeah.
So if I recall, and like you did, tell me if I'm wrong, the thrombosis rate or the occlusion rate on the artery is actually pretty low,
Yeah,
right?
exactly.
Like
It's
what is
around
it actually?
10% in all
Yeah,
population.
it's low. Like I recall, you know, and there's my recollection is biased. I recall a left replace left hepatic going down, but it's pretty rare for the actual artery to go down. These are events that happen in the operating room. A patient that's highly selected is ECOG 1 or 0, good performance status, that there's a prolonged clamp time or something. And this was initiated that, you know, you can have a patient that everything goes smoothly and they have the most rocky postoperative course with patent vessels and, you know, liver dysfunction and ultimately may or may not recover. And then you have another patient that it goes fairly rocky course in the operating room, not as smooth as you like, and they do absolutely fine. Their LFTs bump to like a couple hundred and they normalize. And so we're trying to get at, you know, there's some kind of underlying, you know, abnormality in a chemo liver that just does not tolerate it. And at what point do we, you know, say, now these are postoperative, so the pitch is thrown, but try to predict who's not going to tolerate an arterial clamp and then followed by a portal venous clamp.
This is incredible discussion. We want to hear everybody, but we need to move quickly. So quick question, quick answer.
Riffing off Dr. Evans, did everyone in the series have neoadjuvant therapy? Do you have any in the series that you can use sort of as a control to understand what's the impact of the therapy on the liver versus this technical aspect?
You mean adjuvant, right?
Neoadjuvant.
Yeah, all patients
All
received
had, so you can't really
neoadjuvant, yeah.
tell.
And we
what-
saw, higher rate of FOLFIRINOX in liver injury group. And we know that FOLFIRINOX is
surprise.
more hepatotoxic compared to JAM-based.
No surprise.
But yeah, all patients had neoadjuvant treatment.
Asif, quick question.
Thank you for a great presentation. Just a quick question. I don't know if you have the numbers. Could you see any difference between events post-operative on imaging on arterial versus venous issues that could lead to liver injury?
Yeah,
Were there any difference? I don't know if you could see it with your
You mean
numbers.
the imaging?
Yeah, I mean,
Yeah.
post-operatively, you could see on imaging.
Yeah, exactly.
Was there any
We-
issue, for example, that maybe, I mean, I would guess that maybe.
Yeah, he
more-
gets it. He gets it.
Yeah.
Quick answer.
We didn't collect all data in long data for imaging, and because we are more focused in the immediately early postoperative day, because we think we have to identify immediately this patient to try to treat, because the mortality rate is really high.
Ugo, quick question.
Yeah, considering that arterial patency is really key, did you check for LDH, which is what we do basically with the liver transplant to
Yeah.
detect an early arterial thrombosis? So it should be checked.
Yeah, I don't have this data, but yeah,
Great
Yeah.
suggestion.
yeah, absolutely.
What we do, we selectively check for that. If there is anything wrong, we immediately get a CAT scan.
Yeah, exactly.
Great point.
Thank you so
Great
much.
discussion, guys. Thanks.
Thanks.
Next paper is also eligible for best paper. The title is Current Trends in Pancreatic Duodenectomy at the US NISQIP Centers. and is presented by Richard Bisht from Rochester, Mayo Clinic.
Good afternoon. Thank you so much for the introduction. It's an honor to be here. I have nothing to disclose. Our approach to pancreas surgery has evolved considerably over the years. In 2022, changes were made to the ACS NSQIP reporting structure. Our goal was to describe trends in management of pancreatic duodenectomy using ACS NSQIP data and to examine the potential effect of this reporting structure change on these trends. The ACS NSQIP pancreatectomy participant use file was queried from 2014 to 2022. We looked at Whipple's performed in adults 18 years and older with any pancreatic malignancy. These were the variables assessed. Intention to treat analysis was used when classifying operative approach. Overall, about 36,000 patients were identified. The proportion of minimally invasive surgery nearly doubled from 6.5 to 12.7%, with this growth being driven by an increase in robotic surgery, which increased from 44% in 2014 to 80% of MIS cases by 2022. The unadjusted 30-day mortality of MIS versus open did not statistically differ, nor did this trend change over time. The unplanned conversion to open rate for laparoscopic surgery was considerably higher at nearly 40% in 2022, compared to about 15% for robotic surgery. Median operating time was shorter for open cases at about 6 hours compared to 7 for MIS. Median length of stay was similar, 7 to 8 days for all three modalities. Neoadjuvant approach more than doubled from 15% to 33% in 2022. And the rate of venous vascular resection also increased slightly from 12 to 14% by 2022. The major reporting structure change that happened in 2022 was the addition of the unplanned conversion to open variable, which may falsely decrease the conversion rate at initial glance because it includes open cases and defines them as not having converted to open. So with this variable, the conversion rate appears to be 13.1% in 2022. However, in reality, this rate is closer to about 20%. Overall, open approach still remains the dominant strategy for Whipple's. However, the proportion of minimally invasive surgery is increasing, and this is being driven by the growth of robotic surgery. Neoadjuvant therapy is also gaining popularity, with about a third of all Whipples undergoing neoadjuvant treatment. The rate of venous vascular resection is increasing slightly as well. And lastly, with the introduction of the conversion to open variable, this may falsely lower the conversion rate if the data is not analyzed closely enough, which is important to remember. Thank you, and I'm happy to take any questions.
Thank you very much. I was a little bit surprised that the open method is still almost 90%. I assumed that would be higher in the US because the implementation of robots are very earlier than it happens in Europe. So can you comment on this?
That's a great point. I agree. I think it is, there's certainly the growth of MIS, but perhaps what you're alluding to is that the rate of growth is not as fast as one would have anticipated. I think that may come down to surgeon comfort. I think people sometimes can be set in their ways, and once they have their preferred method, they may continue on with that. And two, it's possible that people are still learning the robotic or the laparoscopic approach, and they don't have the skill set yet for that. But I think with our newer generation of trainees, with robotic surgery and minimally invasive surgery being kind of at the forefront of that, we may see a faster acceleration.
Okay.
Yeah, I actually, the 2023 data came out a month before the abstracts were due for this, or a couple of weeks. And there was a big jump between 22 and 23 with respect to MIS. It's been creeping up 11%, 13%. It jumped to 20% in 2023. So that's a big change. The other thing, you have to be careful, I think, when you look at your neoadjuvant data, because the real answer is that we're at 50% or more now if the denominator is just the pancreatic cancers. Overall, it's maybe a third, but when you look at the pancreatic cancers, the neoadjuvant has gone from as low as 7%, 15 years ago, up to 50% more recently.
Those are great points. Thank you. And for our manuscript, we will be including the 2023 data.
Okay, thank you very much.
Thank you.
Our next paper, once again, eligible for best paper. And again, we'll see Joseph Habib from NYU presenting a paper entitled Neoadjuvant Chemotherapy for Intraductal Papillary Mucinous Neoplasm Derived Pancreatic Cancer. Joseph?
All right. I'd like to thank the Pancreas Club for the opportunity to present our work. I have nothing to disclose. So the management of IPMN-derived pancreatic cancer is largely extrapolated from the more common and traditional pannin-derived pancreatic cancer. And the benefit for chemotherapy, as we talked about earlier today, even remains controversial in this cancer entity. More so, the role of neoadjuvant chemotherapy is even more poorly understood, and there's no current recommendation in the most recent guidelines regarding neoadjuvant chemotherapy. Now, today, there's only a couple papers out there that have addressed this topic. There's one study from the Mayo Group in Rochester that published on 26 patients who got neoadjuvant chemotherapy in IPMN cancer, and there's a large study from Japan that had 40 patients. So the central aims of our study were twofold. First, to evaluate the role of neoadjuvant chemotherapy in these in IPMN-derived pancreatic cancer, and secondly, to assess the prognostic utility of CA19-9 dynamics and to look at pathologic tumor response in these cancers. So we performed an international multi-center retrospective study. 8 centers were involved. You can see them below. And what we did is we took all patients who had resected IPMN-derived pancreatic cancer and split them into 2 groups, the upfront surgery group and then those who got neoadjuvant chemotherapy followed by surgery. For the analysis, time 0 was the date of first treatment, so it was either you got chemotherapy or surgery. We assessed CA19-9 dynamics and pathologic response using the CAP system. Then we performed a multivariable Cox regression to determine factors that were associated with survival in patients that underwent neoadjuvant chemotherapy. We had a total of 1,019 patients in this study, and interestingly, 7% of patients got neoadjuvant chemotherapy, a total of 76 patients. Interestingly, there was a clear selection where neoadjuvantly treated patients had higher baseline CA19-9 levels and were more likely to have advanced NCCN resectability status. What was also interesting is that end stage and margin status was not different between these 2 groups. Here you can see in figure A, patients in the blue are patients who had a normal CA19-9 and remained normal or had an elevated CA19-9 and normalized, and they had an associated survival that was superior to those patients who had an elevated CA19-9 that remained elevated or patients who had a normal CA19-9 that became elevated on neoadjuvant chemotherapy. In panel B, you can see patients who had a complete path response or patients who had a marked path response had also superior survival compared to patients with a partial or a poor response to chemotherapy. And here is our risk-adjusted Cox regression. What's interesting is that NCCN resectability status was no longer or was not significantly associated with survival after neoadjuvant chemotherapy. The limitations of the study first is it included only patients that underwent surgery. And this is particularly difficult in IPMN-derived pancreatic cancers because it's very difficult to tell if it's IPMN-derived in the preoperative setting. Typically, you need, histology to, be confident about this. Again, there's a limited sample size here, although it is the largest study to date. And there's also heterogeneity in the type, dose, and duration of neoadjuvant chemotherapy in the study. For final conclusions, this is the first study to validate that in IPMN-derived pancreatic cancer, biologic treatment effect can be assessed with CA19-9 dynamics and then confirmed by pathologic response on final histology. And then after neoadjuvant chemotherapy, NCCN resectability status was not associated with survival. Thank you.
Thank you very much. Impressive work. So should these patients get neoadjuvant therapy? There's no difference in the tumor stage with survival?
Yeah, so I didn't show that figure, but you see patients with upfront surgery, and we compared them to patients who got neoadjuvant chemotherapy, and they had very similar survival. I think patients with borderline and locally advanced cancers, giving neoadjuvant therapy appears to be, beneficial in this cohort, but there's no data to support, in resectable disease.
Steve?
Thanks. Wonderful data. Thank you for bringing it forward. I just a simple question for you. On a case, I'll give you the context. So oftentimes in an IPN-driven tumor, it's hard to really assess the tumor radiographically. So we really love CA19-9, but we definitely see in not the IPMN setting, on occasion, the CA19-9 continues to drop where radiographically, clearly we're losing control or even seeing frank progression. That's usually a very ominous sign. Did you encounter that at all in this nice series of over 1,000 patients?
Yeah, for sure. And one thing that we did, I didn't comment on, is RECIST criteria, and looking at patients who, on imaging, serial imaging, to see if they got, if we had a concordance or discordance between patients who had increase in CA19-9 or decrease in CA19-9, and see if that correlated with RECIST criteria. We didn't actually look at that, but that would be an interesting thing to
I know
look at.
these were surgery only. Do you have any idea about what percentage of the time one sees this in the IPMN tumor that's being treated neoadjuvantly?
So we saw that.
CA19-9 actually ceases to be a good marker.
Yeah, so I don't have that. I can't answer that question confidently. However, we saw that at least 50% of patients did respond to chemotherapy and actually had elevated CA19-9s that normalized. So it appears to be a good marker, but that'd be interesting to look at those patients who, are, fit that cohort. Yeah.
Thank you.
Dr. Gupta, quick questions, quick answers, okay?
Here. So my question is, this is a large database and you had given up new adjuvant chemotherapy. Did you see any difference in the pathological complete response in IPMN compared to PDAC?
Yeah, so the Mayo Rochester group actually looked at that, and they saw no statistical significantly difference in patients who got pan-derived, who had pan-derived PDAC and received neoadjuvant compared to IPM-derived. In our cohort, we only had one patient that had a complete pathologic response, so we don't have enough patients to comment on that.
Great, Dr. Evans.
I assume you didn't exclude the patients who were FNA negative for invasive cancer. Right?
All these patients had a tissue biopsy.
Pre-op.
Preoperative, yeah.
And they all had cancer.
Yes, correct.
Invasive cancer.
Correct.
Okay.
It's great. Thank you very much.
Thank you.
And again, we have a paper which is eligible for best paper, and the title is The Operative Study, Results from a Worldwide Snapshot Survey. Operative stands for Anticoagulation Platelet Treatment in Pancreatic Resections Involving Vascular Reconstruction, and is presented by Alessio Marchetti from NYU.
Thank you again for the opportunity to present this other study, the approved study, and results from our worldwide survey. So I have nothing to disclose. So vascular resection have become more commonly in management of borderline resectable and locally advanced pancreatic cancer. However, this procedure don't come without cost. Indeed, PDAC has a strong prothrombotic profile, and adding vascular reconstruction further increase this thromboembolic risk. So the antithrombotic management is a key challenge in this patient, and both anticoagulant and antiplatel therapies must be carefully balanced to prevent the thromboembolic events, but also to minimize the risk of bleeding complication. However, strong evidence on the management of antithrombotic therapy in pancreatic surgery with vascular reconstruction is lacking, as confirmed by the recent guidelines from EHPBA Association, and also the recent Rediscovery International guidelines that conclude the same, that the data are inconclusive. For this reason, we conducted this study to describe the current clinical practice for antithrombotic management after pancreatic surgery involving vascular reconstruction at high-volume pancreas centers. And we designed a worldwide-based survey that was distributed by personal mail to 123 expert surgeons performing pancreatectomies with portal vein and/or arterial reconstruction at high-volume pancreas centers. And the survey included a specific question on antithrombotic management after different types of vascular reconstruction. And particularly, we ask about management after partial vein resection with direct closure or patch reconstruction, segmental vein resection with end-to-end anastomosis, human graft reconstruction, prosthetic graft, and also arterial reconstruction. Among the different antithrombotic protocols that were described, we identify 4 main antithrombotic protocols: prophylactic heparin alone, aspirin alone, prophylactic heparin combined with aspirin, and aggressive protocol defined as any different practice than the previous 3 one. For the comparative analysis, we combine the response from the Asian and the European as they have similar practice. And finally, we perform a logistic regression to identify the factors associated with the use of antiplatel and the aggressive protocol. So 80 surgeons completed a survey from 51 centers for a response rate of 65%. That it's quite good for a group of busy surgeons. And most of them were from Europe, 30% were from US, and 11% were from Asia. And here you can see all the centers that participated and the number of respondents from each. So most of the respondents were from academic institutions and declared to perform more than 100 pancreatectomies per year. And nearly 50% of them also perform between 10 and 30 pancreatectomies with major vascular reconstruction. Additionally, more than 13% of them also perform more than 50 pancreatectomies with major vascular reconstruction. And regarding the type of vascular reconstruction performed, most of them declare to perform partial vein resection, segmental vein resection with end-to-end anastomosis and human graft reconstruction, and also hepatic artery reconstruction. 64% of them also perform vein reconstruction with prosthetic graft, and 54% of them also perform SMA resection. Additionally, 81% of them declare to perform also pancreatectomy with both vein and arterial reconstruction. And this finding confirms that our cohort consists of highly experts in these fields. However, this high expertise, we found huge variability in antithrombotic management. 14 different antithrombotic protocols were described, and 11 different antithrombotic protocols were described for prosthetic graft, where the antithrombotic management is even more important. So then we analyzed the antithrombotic practice after each different type of vascular reconstruction. And for partial vein resection, 57% of respondents use prophylactic heparin alone, 18% prophylactic heparin combined with aspirin, and 17% aggressive protocol. And we found similar results for end-to-end anastomosis, with 54% of respondents prefer prophylactic heparin alone. And again, prophylactic heparin alone was the most commonly reported protocol, also for segmental vein resection with human graft reconstruction. However, in this setting, 36% of respondents prefer aggressive protocol. And this approach was more even evident for prosthetic graft reconstruction, where 81% of respondents prefer aggressive protocol. For arterial reconstruction, the most common practice was prophylactic heparin combined with aspirin. And this difference were statistically significant, with prophylactic heparin alone as the most commonly reported protocol for partial vein resection, segmental vein resection with end-to-end, and human graft reconstruction, aggressive protocol for prosthetic graft reconstruction in vein, and the combination of prophylactic heparin and aspirin for arterial reconstruction. So then we analyze also the different practice across different regions, and we found statistically significant difference between European and Asian respondents and American. So for partial vein resection, European and Asian respondents prefer prophylactic heparin alone, and in contrast, respondents from US prefer prophylactic heparin combined with aspirin, and the same findings and the same difference were present also for partial vein resection with end-to-end anastomosis and with human graft reconstruction. After prosthetic graft, Americans still prefer prophylactic heparin combined with aspirin. And in contrast, most of respondents from Europe and Asia declare to use aggressive protocol. No difference was found for arterial reconstruction, where both groups mostly use prophylactic heparin combined with aspirin. So finally, we perform multivariable analysis to evaluate associated factor with aggressive protocol and antiplatel therapy use. And being from Europe and Asia, as well as human graft reconstruction and prosthetic graft reconstruction for vein were found to be associated with the use of aggressive protocol. And for the use of antiplatel therapy, being from US and arterial reconstruction were the associated factors. So in conclusion, a huge variability in the management of antithrombotic therapy was found for pancreatic surgery with vascular reconstruction, even among the mainly expert in this field. And this variability was mainly driven by region difference and type of vascular reconstruction performed. So as the antithrombotic management is often unique for each institution, only multi-center study will be able to build strong evidence on this field. So for this reason, we designed this multi-center international study to evaluate the association between thromboembolic and also hemorrhagic complication and the different protocols for antithrombotic and antiplatel therapies. And already 21 centers have agreed to participate in this study. Thank you for the attention.
Very interesting data and very well presented. These are probably just the results of the hospital stay antithrombotic management strategy. I think, or I assume that they changed when a patient got discharged, of course. Have you looked at this too?
Yeah, these are results only data for hospitalization, because this is a survey and it's always difficult to cover all aspects of this big field. So we focus only on post-operative management of antithrombotic therapy.
Yeah, my question is a bit similar. So I was part of the European guidelines looking at the evidence on anticoagulation, and we were quite surprised that there is basically no evidence except for reporting thrombotic rates and so on. So my question is, in the portal vein with different resection types, what kind of anticoagulation would you recommend and for how long?
Mm-hmm.
With the evidence you generated already?
Yeah, I think I don't have yet this answer because, this is just a survey. Maybe with the result of the multi-center study that we designed, we will have not all the answer, but better evidence. Thank you.
Cool.
Nice talk. First, a comment. We are debating a lot on how to manage people after vascular resections. A lot of this meeting is on that, which is nice because we have evolved our mentality in a few years to be condemned to that because resetting the vessels on discussing how to do it. By having said that, you said that a lot of people recommend antithrombotic prophylaxis with heparin. So it means that there is no specific antithrombotic prophylaxis because this is the standard. And this is the point. If you do a vein resection, basically you don't need enhance, at least based on your survey, and I believe that this is the feeling of most of us, you don't need to increase the standard DVT prophylaxis. Is that correct?
Yeah, apparently from the response that we obtained, yeah, most of people use
And this is what I
prophylactic
feel, you know, because if you do a standard portal vein resection, so I mean, not something very complicated, needing a jam graft and blah, blah, blah. Basically, there is no clear increased evidence of portal vein thrombosis risk. So you don't need to put the patient at the risk of bleeding because of that. So you simply need a standard prophylaxis. The issues regarding the artery, especially maybe the hepatic artery, because they are really smaller in caliber, is something we did not discuss before. If they had cholangitis, that's the risk for liver dysfunction and hepatic artery thrombosis.
Thank you.
Thank
so
you.
much.
I'd like to thank everybody for hanging in there. We have 2 short and 2 long papers left in this session, and then we'll have a very short business meeting immediately to follow. The next paper in the session number 39 is iron deficiency anemia decreases survival in post-pancreatoduodenectomy pancreatic ductal adenocarcinoma patients presented by Joseph Gorman, representing his colleagues at Thomas Jefferson University.
Good evening, everyone. Thank you for the introductions and to the hosts of this meeting for allowing me to present this work with you all today. I have no conflicts of interest to disclose. So as we know, pancreatic duodenectomy is the mainstay treatment for resectable pancreatic ductal adenocarcinoma. However, due to the resection of the duodenum and proximal jejunum, which are key sites for micronutrient absorption, patients are at increased risk for postoperative malabsorption syndromes, including iron deficiency. Now, previous literature has demonstrated that anemia is prevalent in cancer patients with certain solid tumor malignancies and has a negative impact on their outcomes. And furthermore, there's evidence that PDAC patients experience iron deficiency anemia at relatively increased rates, particularly in the postoperative setting. However, the prognostic significance of iron deficiency in pancreatic cancer patients, and especially in the postoperative setting, is less well established, and thus, this study aimed to evaluate the prevalence of iron deficiency and its impact on postoperative survival in post-resection pancreatic cancer patients with a particular focus on those with PDAC. So our study used a 2-pronged approach. Our first approach was a multi-institutional analysis using TriNetX, which compared the prevalence of iron deficiency between post-resection pancreatic cancer patients and propensity score matched healthy controls. And then additionally, we analyzed survival outcomes in post-pancreatic cancer or post-PD pancreatic cancer patients, with iron deficiency versus matched controls with no iron deficiency. And then we next followed this up with a retrospective review of 62 PDAC patients from our Thomas Jefferson University Hospital pancreatectomy database. And we applied a k-means clustering algorithm to group these patients by hematologic markers of iron metabolism, including hemoglobin, TIBC, TSAT, and ferritin. And we then used Cox regression models to assess the survival in these groups. And additional Cox models were also used to assess survival based on iron indices as independent prognostic markers. Now, looking at the results, in our first TriNetX cohort of over 19,000 matched patients, post-PD pancreatic cancer patients had consistently higher rates of iron deficiency, indicated by low hemoglobin, iron, transferrin saturation, and a higher utilization of IV or PO iron therapy at the 3 to 6, 6 to 12, and 24 to 36 month intervals when compared to healthy controls. In our survival analysis of just over 2,100 matched patient pairs, iron deficiency was associated with decreased overall survival and significantly decreased metastasis-free survival in our post-PD pancreatic cancer patients. Finally, moving on to our single institutional cohort, patients grouped into clusters characterized by low ferritin and low transferrin saturation, and this is particularly visualized as clusters 1 and 3 here, had significantly worse survival. And further modeling demonstrated that low TIBC and low ferritin were both associated independently with increased mortality risk. Advanced nodal staging, R1 margins, and perineural invasion were also included in these models, and they were also significantly associated with poorer outcomes. In sum, our findings highlight that iron deficiency is not only prevalent after PD, but may be an unrecognized marker of poor prognosis in these PDAC patients. And this underscores the importance of routine iron studies and postoperative surveillance, and may also necessitate the timely initiation of iron replacement therapy where appropriate. Thank you very much.
Really nice work, nicely presented. In your cohort, do you have any evidence that this is something actionable, that, you know, you had suggested that iron repletion is something we should do? Within that cohort, do you have any examples of, or cohort of patients that started out low, they had pharmacologic intervention, they were given iron supplement or IV iron, and that it actually, did it convert them to a better survival?
That's a very good question. Thank you. And we did not actually evaluate any patients in the scenario as you proposed, but it presents a very good direction for future research.
In the Thomas Jefferson cohort, when did you measure these labs?
Yeah, so all of the labs were taken at least 1 month after the postoperative period to ensure that they weren't relatively caused by bleeding, and they were all within 1 year of their operation as well.
Yeah, I think Chris's point, you know, following up on that question, looking at this is a very dynamic lab value. So one snapshot in time is one thing, but I think looking at it longitudinally will be a really important thing to do.
That's a very good question as well. And I don't know the answer to that off the top of my head. What I can say is that I think that there's a clear issue here where there are probably patients who are dealing with chronic disease anemia. And so we need to be able to differentiate that. One thing that we did that we didn't present here was another Cox model where we utilized groupings based on different diagnoses, based on the markers, placing patients into categories of pure iron deficiency, chronic disease anemia, and a mixed etiology. And truthfully, very few of them had pure iron deficiency, but there was a relatively large cohort to compare who had mixed etiology versus the chronic disease patients. And we did see that those patients with mixed etiology were at increased risk of mortality.
Great. Thank you very much.
Thank you.
Our next paper is again eligible for best paper. The title is Reappraisal of Surgical Indication of Mucinous Cyst Neoplasm of the Pancreas, a Systematic Review and Meta-Analysis. And it's presented by Yoon-Soo Seo from Seoul National University Hospital, Korea.
Thank you for your kind introduction. Mucinous cystic neoplasm, MCN, takes 8 to 20% of among all resected pancreatic cystic lesions. Epidemiologically, it is known to be predominantly female, middle-aged, and body tail of the pancreas. The clinical significance of MCN is that these lesions have the potential for malignant transformation, and in the existing literature, the reported rate is about 0 to 34%. And in terms of actual survival, MCNs without invasive cancer have very excellent survival compared to the invasive cancers. Compared to IPMN, the guideline for MCN is much broader, and 2 guidelines mention surgical indication for them. For IAP guideline, surgical resection is recommended for all surgically fit patients. And for European guideline, more conservative than surgical, but it is still recommended for cyst size larger than 4 centimeters, symptomatic or having any risk factors, including mural nodules. Although then they still include the vast majority of MCN as candidates for surgeries. However, we may need to think about these practices. The graph shows the rate of high-grade dysplasia and invasive carcinoma in MCNs reported in studies with relatively large MCN cohorts by year of publication. This, then, as shown in the graph, there is a gradual decrease in the rate over time. This suggests that the tumor malignancy rate may be lower than our expectations. Also, there was change in the diagnosis MCN in 2000 WHO classification criteria, defining the surrounding ovarian type trauma, unlike the past diagnosis. This change clarified the boundaries between IPMN and MCN, then older literatures should be reassessed for the possibility of integrating other cystic neoplasm as MCN. These changes also lead to decreased reported number of malignancy in MCN and the necessity to reassess the actual status of MCNs. And compared to branch duct type IPMN, MCN seems to have less aggressive characteristics. While the malignancy rate of BD-IPMN is higher than MCN of 31%, the IAP 2023 guideline recommends surveillance in the majority of BD-IPMNs as expansion of surveillance strategy. Then survival comparison between invasive IPMN and invasive MCN have also shown in the graph that invasive MCNs have better overall survival and cancer-specific survival compared to IPMN, then challenging the current recommendation of aggressive surgical resection for almost all MCNs. Furthermore, there was some study tried surveillance in MCN. In those reports, MCN with aversion feature or not didn't show difference in 5-year survival. Another study reported that cumulative malignancy list of MCN gradually increase over time. However, in the report, the recurrence rate and disease-free survival rate showed no difference between immediate surgery group and surveillance group. Then we have to think about those questions. What is actual malignancy rate of MCN, and what are the malignancy predictive factors we can utilize in clinical areas, and then what is optimal surgical indication for MCN? Therefore, the aim of the study was to assess the actual proportion of malignancy among resected MCNs and identify preoperative malignancy predicting factors suggesting optimal surgical indication model for MCNs. The systematic review and meta-analysis followed the PRISMA guidelines, and we searched for resected pancreatic MCN articles published from 2000 to 2024. Then 2 independent reviewers screened the candidates independently. And finally, 53 articles were selected as eligible studies. A major inclusion criteria was announcing the diagnostic criteria of MCN, obviously, based on 2000 WHO classification criteria. And for collecting data for high-grade dysplasia and invasive carcinoma, the studies that clearly announcing the histologic grades were only included. Those ones with used terminology or pathology lesion ambiguously or data integration with other types of cystic lesion or using cancer registry data were excluded. Then here's the leisure part. Among 53 studies, 4,384 cases of resected MCN were collected. All studies were retrospective observational studies, and the proportion of single center was 77%. Mean age was 48 years, and the male patient of 5.6%, and body tail lesion 19%. Here's the funnel plot of publication bias and with no significant bias. And bias assessment with Robbins E2 is here. About 45.3% showed low risk of bias. Then in this slide, we classified malignant MCN as high-grade dysplasia or invasive carcinoma MCN, which are the definite candidate for surgery. Then the pooled proportion of malignant MCN was 17%. And the pooled proportion of invasive carcinoma alone was 11%. This was relevant to previous literatures of 10 to 20% of rate of malignancy. Next, the malignancy predictive factors were analyzed. In age, older patients showed more malignant MCN, and age mean difference was 5.4 years. Other clinical factors, sex was associated with malignancy, and the male patient showed odds ratio of 3.2. Another factor, presence of pancreatitis, showed no significant association of odds ratio 1.2. Then serum CA99 level was associated with the malignancy, and patient with higher CA99 level was associated with a malignancy of odds ratio of 3.4. For radiologic features, cyst size showed significance, and larger cyst was associated with malignant MCN. The mean size difference between malignant and benign was 30 millimeter, and the average size of malignant MCN was 83 millimeter, range from 45 to 119. And for SRO6 analysis, the optimal cutoff for size was 65 millimeter. This number was larger than the current European guidelines, 4 centimeter. Then with careful selection, we can observe more proportion of MCNs rather than immediate surgery. For mural nodule, its presence was associated with malignancy of odds ratio of 5.1. Cyst wall thickening also associated with malignancy odds ratio of 11.4. However, other factors such as location of lesion or presence of septum was not associated with malignancy. In summary, the proved proportion of malignancy, which is high-grade dysplasia or invasive carcinoma, in resected MCN was 17%, and the proportion of invasive carcinoma alone was 11%, relatively low percent. To compare, the other meta-analysis of proved malignancy rate of IPMN was 31.9%, much higher than that of MCNs. Then, preoperative malignancy predictive factors in MCN were in clinically older age, male sex, and higher CA19-9 level, and radiologically larger cystic size and presence of mural nodule and thickened walls. Therefore, by this evidence, we can propose optimal surgical indication should be if there's larger cyst size more than 6.5 centimeter, or presence of mural nodule, or presence of wall thickening or elevated serum CA19-9, we should consider immediate surgery rather than observation. And especially with older aged male patients who even more in risk of malignant MCN, immediate surgery should be considered more strongly. Our meta-analysis still has limitations. This study included only retrospective observational studies, and the study group's heterogeneity varies from low to moderate and even higher. Also, there was lack of researches that covering preoperative variables such as CA19-9 or radiologic factors, and exclusion of studies without definite description of histologic grade or diagnosis should lead to omission of several proportion of reported MCNs. Due to those limitations, this study still cannot draw strong conclusion, and those results should be interpreted with caution. Beyond current limitations, future directions of MCN research should be like those. The natural history of MCN should be studied more to show evidence of surveillance. As current studies mostly focused on the resected MCNs, there are lack of MCN data which were not resected. One of our ongoing study is trying to integrate data of MCNs with surveillance approach with resected ones, evaluating actual natural history of MCNs. Also, there need to evaluate individualized malignancy predictive factors and their individual risks. It is to ensure more tailored and stratified risk evaluation for MCN by assessing impact size of each factors or the meaning of the number of the risk factors. There's also ongoing international study for MCN in order to individualize the surgical indication. It is collecting data of resected MCN from 14 countries and 34 centers and total 1,900 cases. And they are finishing collecting data and now gonna process and analyze the data now. Maybe if it goes as scheduled, we can see the result of the study next year or later this year. This will help our understanding of MCN as the largest cohort study. Furthermore, to increase accuracy of diagnostics tools, something novel diagnostics tool or algorithm should be developed behind existing techniques. This last slide, summarizing one more time, the overall pooled proportion was relatively low instance, and the malignancy of MCN was associated with older age, male sex, higher CA19-9, larger cyst size, and cutoff of value of 65 millimeter, presence of mural nodule and wall thickening. In conclusion, current guideline for MCN is too liberal and it should be revised further. Routine dissection of all diagnosed MCN may not be warranted, and given the low malignant potential. Thank you for your kind attention.
Thank you very much. Very interesting data. But as we've shown, that the median age of the patients suffering from MCN is, I think, 43 years. This is relatively young, and the risk of malignancy, as we showed, is between 11 to 15%, which is appears to me relatively high. So. And most of these lesions are located in the tail or body of the pancreas, which can manage by a minimal invasive left resection. So putting all together, one need to ask what is the best strategy for those young patients with, I think, relative high risk for malignancy. Should we put them under follow-up? And how often and so on? Should we manage them like branch duct IPMNs? Or would you rather recommend operation?
Thank you for your great question. We need more studies for these strategies, but I think the clinical characteristic of MCN is that, as you said, young patients, and or about middle-aged and fit patients, and body and tail, which is easy. There's easy surgeries for MIS.
Right.
However, in contrast, those young patients are very active in social working or in their family members. So if we can avoid the invasive surgery, and I think we can choose the surveillance if
Okay.
the patient wants.
Any comments or questions from the audience? Thank you very much.
Our next paper, the penultimate paper here is number 41, validation of a novel staging system for pancreas ductal adenocarcinoma that incorporates neoadjuvant therapy, National Cancer Database Study, presented by Jason Lazalik on behalf of his colleagues at the University of Nebraska Medical Center.
I'd like to thank the Pancreas Club for the opportunity to present today. We have no disclosures. The use of neoadjuvant therapy for resectable pancreatic ductal adenocarcinoma has increased over time. The current AJC 8th edition TNM staging system does not account for receipt of neoadjuvant therapy. Previous institutional data presented in this forum has suggested that a staging system incorporating receipt of neoadjuvant therapy provides better prognostication than the current AJC 8th edition staging system. Therefore, we aim to validate these studies using a large national hospital registry database. We utilize the National Cancer Database participant user file for pancreatic ductal adenocarcinoma from 2004 to 2021. We included patients that had non-metastatic pancreatic ductal adenocarcinoma, underwent surgery, and received at least 1 month of systemic neoadjuvant therapy. We excluded those patients with missing staging data, survival data, or treatment data. The main outcome was overall survival, and we plotted this on Kaplan-Meier curves. Here you can see a side-by-side comparison of the current AJC 8th edition staging system and the proposed neoadjuvant staging system. Key differences are highlighted in yellow. Focusing on T stage, now we take into consideration pathologic response to therapy, with those patients with no residual tumor accounting for patients with T1 stage, with progressive increasing tumor size, upstaging T stage. For end stage, we now dichotomize patients into nodal positivity alone. And then for TNM staging, we have altered stage 1A to include those patients that had a pathologic complete response, and then all prior AJC stages were upstaged. For example, patients with T1N0 disease after neoadjuvant therapy under the current staging system would be categorized as stage 1A. However, in this new system, these patients are now staged as 2A. Overall, our cohort included just under 27,000 patients. Half of those patients were male with a median age of 66 years of age. 72% had tumors in the head of the pancreas, and about half of those patients underwent pancreatic duodenectomy. Nearly 34% of the patients received neoadjuvant therapy. Neoadjuvant therapy utilization increased linearly over time. And to Dr. Pitt's point, at the beginning of the study, 12% of patients received neoadjuvant therapy, but towards the end, nearly 60% of patients were receiving neoadjuvant therapy. And for those patients that received surgery first, about 67% received adjuvant therapy. The median survival for our cohort was 24.2 months with a 5-year overall survival of 24%. Here you can see that while both staging systems had a statistically significant difference by prognosticating survival by stage, there is a prognostic difference with the proposed staging system as well as a wider range of survival outcomes. For example, with the current AJC staging system, patients with stage 1B disease had a median survival of 29 months, with patients with 2A disease having a survival of 26.1 months, a difference of 3 months. For the new staging system, we see patients with stage 1B disease with a median survival of 42 months, with a 13-month difference for those patients with stage 2A at 28 months. So overall, we conclude that patient with the new staging model that it is able to better prognosticate differentiation of survival. It has a wider range of survival outcomes. So We conclude that this study should confirm that incorporation of neoadjuvant therapy should be used in further staging systems as it improves prognostication for patients.
Thanks for the presentation. Amar, quick question?
I don't have a quick question. I just have a quick comment. So we presented this model last year, and I really appreciate people in the group putting in the effort to validate it. And I'm glad to see that you were able to see similar results. So I appreciate your effort.
You're welcome.
Okay, great. Thank you.
All right.
Yeah.
Sorry, we already left one last paper, which was scheduled as the first one and is again eligible for best paper. Clinical and molecular characteristics of patients with young versus adult onset pancreatic adenocarcinoma. And it's presented by Adriana Gamboa from MD Anderson Cancer Center, University of Texas.
Good afternoon, and thanks so much for the opportunity to present our work today. I have no disclosures. The rise in early onset pancreatic cancer is an emerging clinical and public health problem. And despite some existing literature studying this, we still do not have quite an understanding of the etiology of early onset disease. As seen on the curve on the left, incident rates in pancreas cancer have steadily increased over the last 2 decades, including in a young onset population. Patterns in epidemiologic data suggest that this is likely related to a multifactorial risk profile of known environmental exposures, such as persistent Western dietary patterns and sedentary lifestyles leading to obesity, as well as shifts in the gut microbiome. At the genome level, our own group at MD Anderson has investigated the influence of KRAS submutations with their distribution seen on the pie chart on the left on long-term outcomes in pancreas cancer, as seen by the Kaplan-Meiers on the right. However, genomic differences between early onset and average onset disease have not been well defined in the literature. As such, our aim was to compare the clinical pathologic, molecular, and survival differences between young onset and average onset patients with pancreatic adenocarcinoma. To do this, we retrospectively analyzed patients with histologically confirmed pancreas cancer and molecular testing available at MD Anderson from 2016 to 2022. Patients were categorized according to their age at disease onset, as young onset defined as less than 50 years of age, or average onset defined as greater than 50 years old. Clinical pathologic and molecular characteristics were compared between the cohorts, and a subset analysis was performed in a surgical population. Our primary outcome was overall survival, and our secondary outcome was recurrence-free survival. Our final cohort included 511 patients, of which 10% were classified as young onset. A comparison analysis of baseline demographics demonstrated that the young onset cohort had a higher proportion of non-white patients, but the groups were otherwise well matched. Molecular analysis also demonstrated a similar rate of KRAS mutations, with a large proportion of patients carrying this mutation, as well as a similar distribution of KRAS submutations and other less frequent alterations, such as TP53, CDKN2A, and SMAD4. Analysis of long-term outcomes demonstrated similar survival, with a median OS of 18.7 months in the young onset cohort and 21.7 months in the average onset cohort. Our findings were mirrored in our univariate analysis, where we found that neither age at disease onset nor mutational status were predictive of long-term outcomes, while only male sex and metastatic disease at presentation were prognostic. Again, we found similar results in our surgical population, where there were no major differences in baseline demographics or mutational status. And again, while there was a trend towards worse overall survival in the young onset population with a median OS of 31.2 months compared to 47.1 months, these results were not statistically significant, likely related to an underpowered analysis. And our recurrence-free survival mirrored these findings as well. So in conclusion, significant differences in the clinical pathologic or molecular profiles and long-term outcomes of young onset and average onset patients with pancreas cancer were not identified in our study. Continued efforts should be made to obtain routine germline and somatic testing in all patients with pancreas cancer. and ongoing and future studies are necessary to really delineate if there are any clinical or molecular differences between these two populations and to support the development of practice-changing clinical trials. Thanks so much. Happy to take any questions.
Thank you very much for the presentation. Some quick questions.
I have one quick question. So we did a very similar analysis in our cohort, and what we found out were things that were similar with two differences. The first one was we looked at the response to neoadjuvant therapy. And what was interesting was that this early onset cohort does not respond well to neoadjuvant. So I don't know if you looked into that in your cohort or not. And then looking beyond these common mutations, we use cBioportal to analyze this in that cohort. And we did find some molecular differences between those two pathways. So there's nothing in KRAS and P53, but if you look beyond that, there might actually be something molecularly different between the two populations.
Yeah, in regards to your first question, our young onset cohort was really only around 50 patients, so sort of limited. And a lot of our patients at MD Anderson come from outside institutions, having received neoadjuvant chemotherapy, and we did not have a really well-powered analysis to look into that, but that's a great point. And then in terms of subsequent studies, we're now looking in a larger data set at co-mutations and seeing if there's a signal there.
Really great and ultra quick. Your conclusions then were contrary to your hypothesis at the beginning. So why do you think then that we're seeing young onset pancreatic cancer?
Yeah, I think that question very much remains to be answered, and I think there's a lot of work being done, not only for pancreas cancer, but for a lot of GI cancers. And I think we're going to continue to study this, and again, looking at co-mutations. Now we can get, MD Anderson is getting essentially routine germline testing and somatic testing on all patients, which we weren't getting before, and now we can do essentially 2 FNA passes to get NGS on all patients. So I think we'll have more data, and I think that'll power our analysis to be able to look at this in more detail. And then our mutational panels have expanded quite a bit since the initiation of this study.
I'm going to ask everybody to wait about 10 more minutes after the end of this paper, if you don't mind.
Oh, we're going to go right into it, huh?
That's what I mean.
Yeah, so we're done. Thank you very much for this. Thanks to all the presenters. Please don't go away. We're going to roll right into the business meeting here.
So thank you.